Good evening, everyone. This is Ann Jeanette, and I am the Director for Infection Control in our facility here at Desert Regional Healthcare Alliance. During our previous monthly Board of Directors meeting, there was some discussion regarding our processes regarding the reporting of specific diseases and potential outbreaks. As you're all aware, we recently became aware of a patient that was discharged, and lab results came in that confirmed he had an isolated TB complex from one of his specimens. The infection control staff then reviewed the electronic health record of this patient, and then through the review they also found that this patient did have some nursing notes regarding this patient that of having some red lesions. Further review of the nursing notes did note that these notations were very descriptive clinically for a concern of possible bed bugs, although that was never an official diagnosis. This patient did share a room with another patient for approximately 1 day, and people that have been infected with TB bacteria but are not yet ill with the disease cannot actually transmit the disease. So this patient's roommate nor our staff is any danger of contracting TB or having true exposure. But when a person develops active TB, that's when they're also symptomatic with cough, fever, night sweats, that kind of thing. It wasn't concerning for this patient since they were non-symptomatic at the time. Because we are required to report both the TB diagnosis but also the possibility of an environmental infestation due to the delay, several questions arose out of our board of director meeting, and due to the time allotted we couldn't answer all the questions that were brought forth. So we've agreed to table those conversations until today, where we could address those together as a review panel and discuss these, and which our findings will be brought back to the next director meeting to share. So let's see. So I'd like to introduce the members of our review panel today. We have Janine, who's our clinical risk manager, and she's going to be speaking to the question of, are there any privacy concerns that we should be concerned with?
Hello, everyone.
And we also have Lindsay, who's our clinical informatics specialist, and she's going to be speaking to the question that came about of how does the surveillance system that NEDS uses contribute to safety and decrease potential spreading of infectious and environmental diseases.
Hello, everyone.
And we have Rachel, who's our quality director, who will also be speaking to what steps that we currently take in using the NEDS to report to the state and our national surveillance system. So I'm going to be discussing on how keeping track of tuberculosis and of bedbug outbreaks is beneficial and the value of our national surveillance system. So with that, I'll go ahead and I'll get started. So I'm going to start by saying that the National Disease Surveillance System is actually fairly complex. It involves reporting of state and locally mandated conditions by healthcare providers and clinical laboratories to health departments. Then the health departments in turn process and use the information for public health services and notify the CDC of conditions that are designated notifiable. So in the United States, requirements for reporting diseases are mandated by state laws and regulations, and a list of those diseases differs from state to state. So one of these notifiable conditions for all states is tuberculosis, and as this remains a significant global health problem, it affects millions of people each year, and it's the second leading cause of death from an infectious disease worldwide after HIV. So the number of TB deaths worldwide is really unacceptable, given that most of these are preventable if people can actually access health care for a diagnosis, and then the right treatment is then provided. So short course regimes of first-line drugs can actually cure about 90% of these cases, and they've been available for decades. So it's just reaching those populations that are in need of it that is the issue. So according to the CDC at www.cdc.gov, reporting of cases of communicable disease is important in the planning and the evolution of disease prevention and control programs. So in assuring appropriate medical therapy and in the detection of common source outbreaks. Most infectious disease surveillance systems rely primarily on the receipt of the case reports that our physicians and other healthcare providers like ourselves provide. This is obviously something that's very important for our national surveillance system. If they don't have the information, then they can't do anything with the data. So the World Health Organization has developed a new 6-point stop TB strategy, and part of this is to develop plans to make anti-TB drugs to be available free of charge to all TB patients. So because many of these patients are poor and may find themselves difficult to afford the medications, the WHO has a strategy that supports this. And one of those elements is to have uninterrupted supply and sustained supply of quality anti-TB drugs. So it's fundamental to their TB control program. So without the data surveillance data that we put in there, they don't know where there's current outbreaks. They don't know when things are escalating. So for this to be have an effective drug supply and management system is essential to controlling TB worldwide. So the TB and recording and reporting system is designated to provide the information needed to plan, procure, distribute, and maintain the adequate stock of drugs. So Powell, Lamb, Sisk, Federline, Seachuck, Lambert, and Buff in 2012 published a research study that said in public health reports that stated investigations among contact to infections TB disease have two primary objectives. One is to identify and treat the contacts of TB disease to prevent any additional transmissions, and number two, to identify and treat the contacts with TB infection to prevent future disease. The working group for the National Electronic Disease Surveillance System presented an article by Dr. Broom at the American Medical Informatics Association in 2001, and Dr. Broom states that information is central to accomplishing the mission of public health. So our surveillance system is obviously that which is our central information system. We have an obligation to provide information where public health is concerned. On to an itchy subject. I'm going to talk a little bit about bed bugs. So during the past 12 years, there's been a resurgence of bed bugs that have been reported in the U.S., Canada, and in European countries, Australia, and in Africa. Bed bugs are not considered vectors, meaning they do not transmit pathogens. Yet the EPA and Centers of Disease Control have recently proclaimed that bed bugs are a significant public health concern. Bed bug bites in enough numbers can lead to anemia, mental health conditions, anxiety, insomnia, and depression in patients. So unfortunately, most of the news coverage about bed bugs kind of focuses on hotels, saying that they're kind of like the highest risk. But in reality, our most vulnerable populations actually live in very low-income housing. A lot of them are physically or mentally disabled, elderly, that kind of thing. Also, homeless shelters, but including hospitals and psychiatric clinics are also at risk as well. The EPA is collaborating with our federal partners, including the CDC and others, as well as working with state and local agencies to better understand these issues and to find solutions. They've created some interagency task force to kind of foster some communications, but again, part of that communication is this database or the surveillance system. So they're working closely with the USDA to identify potential existing compounds for bed bug control. They're encouraging researchers and pesticide companies to actually develop new tools. There's actually an increased resistance of bed bugs to commonly used insecticides. So because of this concern, the EPA has committed to giving any application for a new pesticide proposed for specific bed control expedited review for consideration. So bed bugs have been found naturally infected with at least 40 human pathogens. So the bed bugs themselves have been infected, but they've never been actually proven to biologically or routinely mechanically transmit any of those. But through thorough reporting, we can help develop public policy to help housing authorities decide on a control strategy to limit the risk of new infections and control existing ones. With that said, I'd like to turn this over to Rachel.
Thanks, Anjanette.
Sure.
So I'll be discussing, as Director of Quality, the steps that we take in using the National Electronic Disease Surveillance System. So the steps that we use in using this system is collecting data using standardized vocabulary, entering the data into a web-based interface, and messaging the data within a compatible format. To provide an example, I'll describe the steps we take at our organization in reporting to the NEDSS for TB, then address how we should approach a system for reporting bed bugs to our health department. The Centers of Disease Control and the U.S. Department of Health and Human Services released a 2009 manual for the report of verified cases of tuberculosis, referred to as RVCT for short. All states have reported TB since 1985, and today all states use some version of the RVCT. The RVCT itself is a form used to collect epidemiological data for active TB cases. At our institution, we have worked with the state health department to train specific staff members on how to complete the RVCT form. It does require some training. The training of the staff and the form itself is what provides the standardized vocabulary, because if not everybody's speaking the same language, then it's difficult to aggregate the data together. The staff members complete the paper RVCT form, then enters the data. The data is transcribed using the state reporting system. The reason for using the state reporting system rather than our own EHR is that the state reporting system was built to be compatible with the national database. The health department retains the paper form with the patient name, but only the case number and the epidemiological data are reported to the CDC. Our lab also automatically reports all active TB cases to the state health department. The state reporting system the staff members use to enter the RVCT data is compliant with the NEDSS compatibility requirements outlined on the CDC's current NEDSS webpage. The requirements are that disease data entry directly through an internet browser-based system, thereby creating a database accessible by health investigators and public health professionals. Electronic laboratory reporting that enables labs to report cases to health departments, integration of multiple health information databases into a single repository, and electronic messaging capabilities, enabling states to share information efficiently with the CDC and other health agencies. While the reporting and surveillance of TB is very standardized, there's not an existing national structure to the same effect for bed bugs. So we've been told by our state agencies that to report, but we should start by contacting our local and state health departments to see if they already have a preferred format or system in place for collecting data on bed bugs. The 2001 article, National Electronic Disease Surveillance Systems, a standards-based approach to connect public health and clinical medicine, discuss the challenges that arise when vocabularies, messages, and case definitions are not standardized. If all the health department requires is the frequency of bed bug cases that we encounter, I believe that would be relatively easy to accommodate. You can correct me if I'm wrong, but I believe our policy is that we only consider it a confirmed bed bug case if one of the insects has been sent to the lab for confirmation, which didn't happen in this case. But if that were to happen and that's all the data that they needed, that would be relatively easy, because we could possibly use the same route of notification that we currently use to forward the TB results to the health department. The 2001, if more data is required, then we need to identify what data is relevant and how and when to report the information. The 2001 NEDSS article also discussed that there are grants available to health departments to implement compatible surveillance systems. So if the health department requires more data than just the simple notification that we had a case, they should establish the structure for reporting. I recommend for our next action is to confirm the data requirements that they would like for reporting of bed bugs, and that the health department then reconvene after we get their response. So that's how the structure of it works, and if they only need that one simple bit of information, I think it would be relatively easy, but if not, and they need more, I think that would put the ball back in their court rather than ours. So that concludes the research that I've done into the topic. So Lindsay, I believe you also had some information on the surveillance systems?
Yes, I did. So what I was tasked with bringing to the team was about how this NEDDS system, or NEDSS surveillance system, supports safety for population health and prevention of disease, spreading of disease. So the first thing that I'll talk about tonight is what the CDC says about this system. It's a system that CDC uses on their website, www.cdc.gov. They describe the NEDS surveillance system as a conduit for the exchanging of information that supports the National Notifiable Disease Surveillance System. It ensures that 46 states, along with New York City and Washington, D.C., are able to share data quickly, securely, and understandably. Much like you were talking, Rachel, it uses standard nomenclature so that everybody's speaking the same language. It also prevents duplicate data entry. I also wanted to go into a few examples where surveillance systems, maybe not the exact NEDS system, but surveillance systems like this were used and had great outcomes as far as patient safety and disease prevention go. First, a study that was published in the Journal of Public Health Management and Practice by Stege, Bauer, Duchin, and Laffey in 2014 found that by just applying standardized definitions for influenza-like illnesses in their ambulatory care EHR, and this was something that wasn't commonplace in ambulatory centers. Initially, they were doing all paper reporting, but they instituted this surveillance system, and it increased their tracking capacity by 300%. And this means that they were more accurately identifying those patients that had influenza-like illness, and they also found a correlation too, because we want our data to actually tell us something. It's not worthwhile to track data that means nothing, but they actually found that the data that they were tracking had a high correlation with positive flu results on lab when they came back. So they were able to identify those patients early on because they had data that was meaningful. So they could start them on Tamiflu or whatever their treatment plan at that ambulatory care center was. So another example that I wanted to give was published in 2001 in the Journal of Public Health Management and Practice. A group called the National Electronic Disease Surveillance System Working Group published in this article about how critical information and the timely collection of that data is to the public safety and public health. The surveillance data that they collected in this example was data surrounding toxic shock syndrome. So they identified that a huge culprit in toxic shock syndrome, what caused it, which group of people did it affect most. They were able to identify that and narrow it down to tampons as being the critical risk factor there. So that was another way in which they were able to identify the risk, get that information out to the public, and we rarely ever hear of someone suffering from toxic shock syndrome because of systems like this. Another example given is in a book called Nursing Informatics and the Foundation of Knowledge. In Chapter 17, Using Informatics to Promote Community and Population Health, it was written by Kraft and Androwich. The example they give is the SARS outbreak of 2002. This was a global threat. It was a scary time in healthcare. But they used a global surveillance system that tracked not only confirmed cases of SARS, but syndromic data, data that indicated early stages of an outbreak. And this allowed them to look at the populations that this was affecting to learn more about the disease, and they were able to morph their disease and symptom definitions to better prevent further outbreaks of this disease. So, in conclusion, I really think that a surveillance system like this, although very complicated, I will give it that, does promote safety and prevent the spread of disease, because it allows us to be more agile in our actions and intervene more quickly, which is going to stop those outbreaks and epidemics early on. And with that being said, I will take it over to Janine.
Thank you, Lindsay. As risk manager, I was asked to sit on this committee and address the question that's been brought forth as to whether or not there are privacy issues in the notification of individuals potentially exposed to M. tuberculosis complex and/or bed bugs. In the case set before us, there are privacy issues we need to address, including Mr. Barnes and any individual who came in contact with him during his stay. Our goal is to protect Mr. Barnes' privacy as much as possible, yet the reporting of communicable disease exposure is a requirement. As stated on the Center for Disease Control and Prevention, or CDC's official website, under Managing TB Patients, General Recommendations, Collaboration with Health Departments, the mandatory reporting rules for healthcare facilities include the notification of state or local health departments so that follow-up, community contact investigation, and completion of therapy can be tracked. The CDC's Morbidity and Mortality Weekly Report, or MMWR, Volume 39, Recommendations and Reports Number 9, states that the reporting of cases of infectious diseases and related conditions has been and remains a vital step in controlling and preventing the spread of communicable disease. And this public reporting supersedes an individual's privacy rights. The same does not necessarily hold true for Cymex lectularius, which we know more commonly as a bedbug. Although local officials are mandating reporting of suspected bedbugs and bedbugs, I still question, and I'll speak to it a little bit later more, I still question whether or not we have enough evidence to move forward with that part of the reporting. However, according to the CDC's official website, under parasites, bedbugs, and bedbug facts, bedbugs should not be considered as a medical or public health hazard as they are not known to spread disease. This does not mean that they should not be notified in order to contain spread of potentially irritating and a symptom-producing insect. What I really feel as risk manager we should be doing is reporting the exposure of the tuberculosis, and then we should be checking Mr. Lister for bites as well as Mr. Barnes. I know Mr. Barnes is already gone, but unless we can get a hold of him or get a hold of his practitioner and get a medical diagnosis, I don't know that we can go backward, attach a medical diagnosis based off some nursing notes when physicians, several physicians, actually examined the patient while he was here. I just have a concern because he was never diagnosed. We don't have any evidence. As Rachel stated, we don't have a corpse to send down. So I'm going to go ahead and speak to this as if we did have enough evidence to report both of them. And we'll discuss as a group whether we'll move forward on that portion of reporting at the end. So according to the CDC's National Center for HIV, AIDS, Viral Hepatitis, STD, and TB's Prevention 2011 Workgroup Study, under Section 5, which deals with the benefits, risks, and costs of sharing data and maintaining security and confidentiality, risks to maintaining the privacy rule include database security breaches, reporting information to the incorrect individual, and incorrect duplication of data. However, as we learned from the National Electronic Disease Surveillance Systems, or NEDDS, working group in 2001, appropriate public health notification includes doing what is necessary for intervention. So we're sitting on a fence. We have to intervene if we have enough evidence that the intervention and the notification outweighs keeping the privacy. In regards to the M. tuberculosis complex, the immediate individuals that have to be addressed include Mr. Barnes, any patients who shared room space with him, his immediate support persons, and anyone who cared for him while he was here. As much as possible, in these instances, we try to protect Mr. Barnes' identity. When notifying Mr. Lister and other potentially exposed individuals, all that we have to release to them is the bacterium and the approximate time of exposure. During the notification, no personal specifics of Mr. Barnes needs to be released. So even though we are releasing information, we can do this in as private a manner as possible. Now, provided Mr. Lister then tests positive, we then have to worry about secondary exposures, including those who came in contact with Mr. Lister and those who worked directly on the job with Mr. Barnes. And if he had an active TB case, trying to locate people he interacted with along his truck route would just prove to be horrific. Like a tree with branches, disease spreads through the community, and each leaf branches out into different neighborhoods. So it is vitally important that we limit exposures as much as possible. A possible exposure to either bed bugs or M. tuberculosis complex requires action. Although studies such as Powell, Lamb, Sisk, Fetterling, Seachuck, Lambert, and Buff, this 2012 report on contact investigation, concluded that tuberculosis does not spread as easy as other bacterium, it is our responsibility to identify and notify those people exposed whenever possible. And as Anjanette reported earlier, one of the main reasons that we do this is because when we have an outbreak of TB, if they don't have a heads up that it's coming, they can't get the support persons and the support medications to the areas they need them to get to. Wheaton's 2013 article, Using Personal Information, Do We Manage Conflicting Interests?, which can be located in Health Informatics Volume 188 under the Digital Health Services Delivery, speaks of the dilemma faced when trying to protect an individual's rights and privacy when they conflict with the rights of the public's need to know. As Wheaton suggests, sometimes we have to take a stance on whether the public needs outweigh an individual's privacy. However, we must be very selective as to how much information is released. The National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention's 2011 work group supports this, stating, harmonized data security and confidentiality standards among programs and a commitment to enforcing them can minimize this. As to whether or not there are privacy issues surrounding the reporting of this incident, my findings indicate the answer is both yes and no. Yes, we must always protect private information to the best of our ability. No, contacting government agencies and any potential exposed individuals and providing them with necessary information is not a breach of privacy. To summarize, when looking at the risk of maintaining the privacy rule during an outbreak of infectious disease, one might ask, when do we and how do we release private information to help the public? Well, we have guidelines. The Department of Health and Human Services 2002 Standards for Privacy, in their final ruling on the Federal Register, Volume 67, support that the privacy rule allows sharing data with public health offices and allows healthcare providers to share information with legally authorized public health entities for a recognized public health need or crisis, including the same factors, surveillance and intervention during an infectious disease outbreak. Therefore, I don't feel we should report this potential bed bug problem, but I do think we have no choice but to intervene and notify appropriate persons and state agencies regarding the tuberculosis complex. So my recommendation to the group would be, one, we carefully protect the privacy as much as possible, but no, it's not a breach to report it, only when it's a necessary reporting. So we need to be really careful about the bed bug part. I'm comfortable with reporting the tuberculosis. I'm not so comfortable with the bed bugs. And that's all I have, ladies.
All right, well, thank you, ladies. I think, well, Well, I think what I'd like to do is kind of start with where we just left off. What is everybody else's comments about the reporting of the bed bugs? I think as far as the TB goes, that's going to be mandatory, and I think that I'll be in agreement with that. We do need to obviously report that. It wasn't a matter of whether we do or not. It's just how we go about that. And I think Rachel covered that quite well as far as that way we can go back to our board of directors and let them know that we actually have specific staff that are trained on these standardized forms. So there's standardized language that the different state agencies and nationally can gather that information. So, but I think with the bed bugs, I think Janine has an excellent point with that. I would like to say I agree. I think, after a patient is gone, there wasn't a diagnosis. There's clinical documentation, but there's no proof of life, proof of death, so to speak. So, what is everyone else's thoughts on that?
Well, Anjanette, this is Lindsay. I concur. I don't think that we really that the benefits outweigh the risks in reporting this bed bug. This possibility of bed bugs. I think there's things we can take, or we can take action as a facility to ensure that the room is cleaned properly to prevent spread if it was indeed bed bugs, and it's not been confirmed, but that we can take steps, just do due diligence on our end, and still protect the privacy of that patient that left. So.
I agree as well. So this case, there's no way we can report because it's not diagnosed. But if our health department wants us to report future cases, I think that we should. We do need to figure out what exactly they want to know, because as Lindsay was discussing in many of her examples, when the time that the surveillance was the most useful came with more data, and like the figuring out about the patients with toxic shock, and we need to find out if they only want to know the frequency that we are having cases, or if they require much more data and figuring out the risks and benefits for that, and how much data collection would be valuable to them. But this individual case, I don't think would get reported. It wouldn't get reported.
And I think too, we know, like I said, the EPA and the CDC did proclaim that they think it's a public health concern, but our public isn't at risk necessarily. We're happy to provide information, but I kind of go back to where, like, who decides it's bed bugs? Do we have an epidemiologist on staff? Do we have someone that says, yes, that's what that is, or are these mites, or that kind of thing? And then do you have to wait? Do you have to send something to make sure that no, that was a bed bug, and what's the turnaround time on that, and what's the cost on that? I think you don't want to they wouldn't want to put up barriers for that. Versus, a confirmed case versus a possible case, and what's possible, I think that's kind of really subjective, and I think there does need to be some specific parameters around that. So, Rachel, I'm definitely in agreement with that. We need to contact our state and local agencies to find out what those parameters are. I'm not an expert in it.
Well, I would suggest too, I didn't see in the notes anywhere that we went back to the practitioner, and the practitioner did not call it bed bugs. Now, the practitioners can look at clusters of bites and make a diagnosis without an actual bug present. So the fact that the practitioner did not note it or diagnose it as bed bug, and that we didn't, there was no testing at the time, follow-up at the time, I just hesitate to say it was the case. We can ask our local officials if this is the kind of thing they want to know, but the whole thing about risk management for me is managing risk. So when we have a known thing or a highly suspicious thing, absolutely I think we should report. I'm not sure if reporting personal information to anybody is correct if we don't have any substantial evidence that that's what it is. And all we have are red lesions, which could be 1,000 different things. So I guess we need to do a couple things. One, I would like the committee to follow up with the practitioner just to make sure that he didn't feel that this was bed bugs, or to make sure they saw the lesions or didn't see the lesions. Because he or she might have a very clear understanding of what they felt it was, and that would end the whole conversation on it. The second thing I think we need to do is, I agree with Lindsay and Rachel, that we need to contact our local officials, our local public health officials, and say, is this the kind of thing you want to know about, or what kind of confirmation do you need? So we're reporting within the required parameters. But most certainly, I think we need to move forward immediately with reporting the TB. So I think that we could go back to committee and say we're going to do a few steps before we decide on the bed bugs, but that we're moving forward with the TB. That would be my suggestion.
We can use this as a teaching moment, essentially. What would we do moving forward, and how would we diagnose, and how would we go about that, and then the documentation of that. So this would just we can say that this case was just kind of served as a conversation starter and a catalyst to developing our plan. So I think that's a great idea. Anything else really specific that anybody feels that I need to take back to the board? I think we really covered all the questions, and I've written down all of our responses for that. Anything specific that we didn't talk about that we should?
No, I think the only thing, maybe designate a contact person. I don't know if Rachel wants to be the contact person. She knows the reporting system a little bit better for the board, and just put one of us sort of as the lead on it.
Yeah, I'll contact our local and state agencies.
Okay, great. I think there was just a lot of misconception of what this national, surveillance system does. It's not a two-way communication. They can't pull information unless we give it to them. And I think just there were some people at the table that really, they don't want Big Brother watching, so to speak, and they do want, to protect patient privacy as well. So, yeah. Okay, well, great. I think we covered everything. And I guess we'll go ahead and we'll present this at our next board meeting, which will be in about 3 weeks.
Okay, thank you so much.
All right, great, ladies. Thank you.
Thank you. Good night.
Good night.